And so we begin the gastrointestinal pathology. First, as usual, I'll start off with the words to remember. I'll talk about some words. The first word is an ileus. What is an ileus? We learned this for respiratory pathology under meconium ileus. That means it's a lack of movement. So in this condition, the stool in meconium ileus, the first stool of the baby is not moving across the GI tract. It's a surgical emergency. Next, a diverticulum. This is similar to an aneurysm. The same concept, it's a blind-sided abnormal pouch formed at a weak point in the GI wall. Okay? Next, this word is a clinical word. You hear this in the clinic. It's called melena. What is this? This is how you ask a patient this. Did you pass black tarry stool? Plus, does it have very bad smell? And is it difficult to flush away? You need to ask a patient these three conditions to diagnose it as melena. So what is melena? It is bleeding in stool, bleeding into stool. So let's take part of the GI tract, and this is a blood vessel. So let's say there is a disease in which blood is now entering the GI tract. This will pass off in stool as black tarry substance because the blood is going to get broken down. Next, another clinical word, steatorrhea. Okay, we learned this in cystic fibrosis, but basically it's fatty stool. So in cystic fibrosis, fat is not digested properly. So you get fatty stool or steatorrhea. Next, a stricture. This is a basic English word, but it basically means stenosis, narrowing. Next, dysphagia, difficulty swallowing. Next, we have a condition of the esophagus called achalasia, that is the absence of relaxation. So we have the normal esophagus here, and we have a part of it which is contracted. Achalasia is the absence of contraction. So what happens then? When there is no relaxation, peristalsis cannot occur. The movement that pushes food along the tract cannot occur here. This will lead to difficulty swallowing first solids, then liquids. And this will increase the risk of esophageal cancer. See, over here you can see the normal part and the achalasia section, the constricted section. Two more words, emesis, that means vomiting. So if you add the prefix hematemesis, that means blood in vomit. Finally, what is a volvulus? This is a loop of the intestine twisting around itself. This will lead to obstruction. Okay? Next, before we start the lecture, I want to talk about the histology of the GI tract. So I'll just draw it. First, I will start with the innermost layer. This is called the mucosa. This is what opens to the lumen. And the mucosa is made up of, this is open to the lumen, therefore it has an epithelial layer. And it has connective tissues. And this connective tissue is a type of soft, loose connective tissue called areolar tissue. There's glands, mucosal glands, and there's a layer of muscles called muscularis mucosa. there's lymph nodes, etc. The next layer is called the submucosa. So the layer which opens to the lumen is the mucosa. Next layer is the submucosa. That is made up of connective tissues which contains glands and the nerve plexus that helps peristalsis and other functions. So basically movement of the wall, the muscles, and release of glandular substances. The next layer is going to be the muscular layer. It's called the muscularis externa. So there's an inner circular layer. The inner layer is a circular muscle layer, and the outer layer is longitudinal in cross section. And finally, we have the adventitia, which is made up of connective tissues. So two types. It could be a serosa, that is connective tissue plus a mesothelium. So that means there's an epithelial layer in the outer surface. So it means it's exposed to the outside environment. This is usually seen in the intestines. And another type is called fibrosa. This is loose connective tissue. So this is basic histology. It's very important for you to understand different diseases. Okay. And what is a mesentery? It's basically something that it's a connection with the wall. With the abdominal wall, it's going to be the connection. And there can be blood vessels, lymph vessels, all those running inside the mesentery. Okay. That is histology of the GI tract. Next, I'll start off with the esophageal diseases. First, I'll talk about the difference in the histology. First, the mucosa is a stratified squamous epithelial layer. So what is stratified squamous? It's several layers, not just one layer of squamous epithelial cells. You can see it drawn here. Then we have the submucosa, which contains esophageal glands. So two locations have esophageal glands. One is in the esophagus. We'll see the next one. Next, we have the muscularis layer. The upper part is made up of skeletal muscles. So that means it's of voluntary control. The middle part is a mix of both skeletal and smooth muscles. Involves in peristalsis from here on. The lower 1/3 is made up only of smooth muscles. And the type of adventitia is a fibrosa. Okay. The first disease of the esophagus, esophagitis. Now, if you watch the previous lectures, you should know that esophagitis is inflammation of esophagus. So what's the first thing that happens in an inflammation? First, there should be something that stimulates inflammation, that causes the inflammation. Next, you have edema. Neutrophils will accumulate next, and finally mononuclear cells will come and progress to chronic inflammation. If it can resolve before that, then it's fine. You get normal structure and function. So here are some causes of esophagitis. Ingestion of corrosive or irritant substances, something like an acid. Radiation or chemotherapy. Prolonged gastric intubation. These are patients who have been put feeding tubes due to different diseases. Maybe they're in a coma. And another condition, this is called GERD, gastroesophageal reflux disease. It's the same concept we learned under Barrett's esophagus. Basically, reflux of gastric contents. And it's usually seen in adults over 40 years of age. So what happens here? Let me draw it. So we have the stomach here, and the contents can come up through this. And remember, once substances are in the stomach, it's going to be mixed with gastric acid. So it will literally burn the wall of the esophagus. Okay. Next, I will talk about the symptoms, different symptoms you can get. First, heartburn. What is heartburn? The patient will describe it as retrosternal, behind the sternal, burning pain. It's not a skin pain, it's from inside. And remember, patients usually mistake myocardial infarction with this. They just think it was an attack of heartburn, not a myocardial infarction. So usually there's a delay in seeking treatment. Next, severe reflux can lead to bleeding or stricture. What is stricture? Narrowing of the esophagus. So what happens when there is bleeding? It will lead to hematemesis, and if the bleeding is really severe, it can lead to melena. Okay. Usually before you get melena, you get occult bleeding. This type of bleeding is invisible to the naked eye. Usually you get that in cancers. Early stage of cancers you can get that. Next, you will have dysphagia, difficulty swallowing, and a chronic cough. This is actually associated with asthma. Okay. So in around 10% of people with chronic exposure to the acids, to GERD condition, can develop Barrett's esophagus. We learned about this. In this, here is the definition given by NMU. The replacement of normal distal stratified squamous mucosa by metaplastic. What is metaplasia? Change in the type of cells. Columnar epithelium containing goblet cells. Okay, there's going to be goblet cells in this type of mucosa. Why? It will help protect the esophagus. It's a protective mechanism. Remember, cell injury, adaptation, one type is metaplasia. But that can progress into dysplasia. Also, you can get ulcer formation, stricture formation, and through dysplasia, it can lead to esophageal carcinoma. So carcinoma is malignant tumor of epithelial cell origin. Okay. So two types, adenocarcinoma and squamous cell carcinoma. Remember this, adeno means glandular. This is associated with glands. So in around 10% of esophageal carcinoma is adenocarcinoma, and adenocarcinoma is associated with Barrett's esophagus. Now think logically. Which region is most commonly going to be affected? Is it the upper region of the esophagus, middle, or lower? Obviously the lower 1/3 is going to be affected, because that's where the acid will come and burn. Okay, this is the connection to the stomach, and that's where the acid will come and burn. This is different in squamous cell carcinoma. Now, squamous cell carcinoma is more common, and it is usually due to environmental and dietary diseases. So remember, vitamin A, vitamin C, and another vitamin, vitamin E, is important to prevent cancers and other oxidative injuries and stuff. Alcohol, tobacco, and hot food are risk factors. So people who enjoy hot food, people who enjoy spicy food are at a risk. Human papilloma virus is another, it's a virus, and you will learn it for microbiology, that increase the risk. And if there is a error in the P53, it's a tumor suppressor gene, you can get squamous cell carcinoma. Okay, so what you need to take from this is Adenocarcinoma is associated with Barrett's esophagus, and it's less common. See, in only 10% of the people with chronic exposure to GERD or esophagitis symptoms can lead to adenocarcinoma. Squamous cell carcinoma, it's more common, associated with environmental, dietary and genetic factors, and the location, it's the middle 1/3. Okay, 50% of the cases are from the middle 1/3. So we will take carcinoma in general and talk about it. First, early esophageal carcinoma. Cancer will be on the mucosa and the submucosa, not the whole wall. It will be the top 2 layers. Okay, this is important. The muscle layer is not involved, and there is no metastasis. So early lesion is basically, it's like a plaque growth, white plaque growth, small gray white plaque, plaque-like thickening. This is the early stages. Later stages, you can get a polyp growth, ulceration, or diffused infiltration. Okay, we have done these for tumors. And next, we have advanced esophageal carcinoma. Okay, if it progresses, it becomes advanced esophageal carcinoma. So squamous cell carcinoma, as you know, it can be poorly differentiated. Actually, any carcinoma, any cancer can be poorly differentiated and well differentiated. The poorly differentiated one, what's the function? Just growth, just cell division. Okay, so therefore this can easily spread to other locations. It can easily metastasize. The other type is well differentiated squamous cell carcinoma, and on histology you will see intercellular bridges and keratin pearl nests. Okay, next, the other type of carcinoma is the adenocarcinoma. We get mucin producing glandular tumors that exhibits intestinal type features. We'll learn about that. And finally, the spreading. So first, it's usually infiltrative type spreading, going into lymphatic spread, and finally into hematogenous spread. I discussed this. So metastasis from lymphatic spread, it can go through the esophageal lymph network. We learned this for anatomy. Remember, the rectum is connected to the esophagus, and it's all through lymph. So there's that spreading pathway, and there's the hematogenous through blood into the liver and lungs. Those are the most common sites of metastasis. So that's it for esophageal diseases. I did it in 18 minutes, the whole. Next, stomach diseases. Don't worry, I'll give the whole note for this one because I'm going faster than usual. I'll give the the note for this. I did the live class for this. I did up to the end of gastritis, but I want to make the video shorter, so I started the whole video again. First, I'll talk about the anatomy. This is something many people forgot, but it is very important. The stomach, you can draw it with me right now. We have the first region, the entry region of the stomach. This is called the cardia. Next, we have a region in which gases accumulate. This is called the fundus. And then we have the body, where you get striated muscles. You get muscles. That is involved in physical digestion, mixing of food, and forming something called chyme. It helps form the chyme. So this is the cardia, fundus, body, and the pylorus region. So there's going to be a sphincter. What is a sphincter? It is basically a group of muscle cells which can contract, relax to release substances through. So we have the urinary system has sphincters to prevent urination on its own. It gives you control. So this is called the pyloric sphincters. And the canal through which this region is called the pyloric canal. We have the duodenum here. And this is just to help you understand cancer spreading, but we have the pancreas here. Okay. There's some basic histology. First, the mucosa has folds. These are called plica. And it also has gastric pits. So here's the folds, and we have these gastric pits. And it's the epithelium is a type of simple columnar epithelium. One layer of epithelium, columnar, with high bicarbonate undissolved mucus. Now if you remember, you can see the metaplasia here brings columnar epithelia with mucus cells, goblet cells. This is basically the stomach cells have come and started divide. That's the metaplasia. Basically, the stomach cells are now present in the esophagus. Okay. So in this case, there's high bicarbonate undissolved mucus and tight junctions. So what's the importance of tight junctions? We have two cells, and we have the harmful acid. It's all over here. The tight junctions prevent leakage. This is cell biology. So it prevents leakage. Look, the acid cannot enter into the deeper layers of the mucosa. That is because of the tight junctions. Basically grabs onto each cell tightly. Okay. The lamina propria has three types of glands: gastric glands, cardiac glands, and the pyloric glands. So these two types produce mucus. So forget about them. We'll talk about the gastric glands, which is present on the fundic region. These are also called oxyntic glands. Two types of cells: parietal cells and chief cells. So parietal cells, look at this. This is for people who are studying histology. Try to always draw the cells so that you can easily remember and understand. These cells are pyramid cells, pyramid-like cells, with a central nucleus. I drew the center in red because it has a eosinophilic cytoplasm, and it has two functions. One is to release HCl, which kills bacteria and activates pepsinogen to pepsin. Remember, protein enzymes are always secreted in their inactive form, because even the lysosome membrane or the vacuolar membrane is made up of proteins. These active protein enzymes can digest that. Therefore, we always secrete as inactive form. So here it's pepsinogen, which is activated by HCl to form pepsin. Okay. The second factor is it releases intrinsic factor, which absorbs vitamin B12, and a deficiency in this absorption can lead to anemia. Okay. It's a type of anemia. You'll learn those. Next, chief cells. Sorry, give me a second. Sorry, I got confused a bit. So the parietal cells, it releases HCl, an intrinsic factor. the chief cells, they are columnar cells with a round basal nucleus, and the basal area is more basophilic. And this is the cell that releases the pepsinogen. Okay, it's not the parietal cells. The HCl from the parietal cells will activate it, but the chief cells release the pepsinogen. Okay, and then you have other types of cells, stem cells, endocrine cells. So ACL cells can secrete histamine, which increases the parietal cell secretions, which increases acid secretion. So that's why we have a type of drug called H2 blockers, histamine 2 receptor blockers. It's a drug we give for patients who are on NSAIDs, non-steroid anti-inflammatory drugs, or people with gastritis. And the other type is D cells, which releases somatostatin that inhibits parietal cell secretions. Okay, this is basic histology. Next, submucosal layer, normal. Muscularis externa has a third layer, an inner oblique layer, because the stomach is involved in both types of digestion, mechanical and chemical. It's going to break down the food and mix it with the acids. And finally, the adventitia is a serosa. So next, gastritis. What is gastritis? As the name says, it is inflammation of the gastric mucosa. Okay, so we have two types. We have acute gastritis and chronic gastritis. Okay, now which is more dangerous? Over time, obviously chronic gastritis is dangerous, but it usually has no symptoms. It's going to progress slowly, does not give any symptoms till it's too late, and it has already become a ulcer, or it has led to cancer, or it starts bleeding. Acute gastritis, it's acute inflammation, usually transient in nature. This is very important. It comes and goes. It's not there all the time. Okay. Some causes include non-steroid anti-inflammatory drugs. The best example is aspirin. So there are patients after MI, myocardial infarction, who are given long-term aspirin. So they have a higher risk of developing acute gastritis. Why? The mucus layer decreases. This is due to a decrease in PGE2. So the mucus layer decreases, the H plus secretion increases, and the epithelial regeneration decreases. So mucus layer, this mucus layer has gone down. Now the acid can easily penetrate this, and there's increased H plus secretion, and any dead cells are not being replaced as fast as it used to. Okay. Also, angiogenesis is decreased. So the blood vessel, like this region's regeneration is low, basically. And what happens then? It's going to penetrate through this layer, expose into the blood vessels, and damage the blood vessels, causing bleeding. Okay, this can lead to acute bleeding. Acute gastritis can lead to acute bleeding. Okay, but usually these patients have the stomach has a very strong regenerative capacity, so it will heal in a few days, but you may get these symptoms: hematemesis or melena. I told you what melena is. Melena is basically stool containing tar-like stool containing blood breakdown products. Next, chronic gastritis. This is the definition from NMU. Actually, anything I put these symbols are definitions given by NMU. So presence of chronic mucosal inflammatory changes leading to atrophy and epithelial metaplasia. When you hear the word metaplasia, you should remember it can lead to dysplasia and it can lead to cancer. Okay, so what's the most important cause of chronic gastritis? It's called Helicobacter pylori. It's an infection and it is usually found in around 60% of the world population, but only in a very small amount, in around 20%, do you get any condition associated with this. So it has two substances it produces that allows it to survive the so what I drew here was basically it produces substances that allow it to live in the acidic environment. Okay, Helicobacter pylori can lead to chronic gastritis, which can develop into an ulcer, or it can even lead to a gastric cancer. Also, these risk factors are important. So the first one is H. pylori. Second one is elongated chronic irritants. Alcohol, smoking, long-term NSAID use, especially in rheumatic arthritis, they need to drink aspirin every day. And people who love spicy or hot food. So next, we have autoimmune injuries. This is the third cause, and this is also very important. This will lead to reflux of duodenal contents. So like I said, the clinical features of chronic gastritis, usually there's no symptoms, but the patient can present with upper abdominal discomfort and vomiting. Okay, this condition is rare, remember that. I will not leave that. I just want to highlight what melena is. I just want to put that into your vocabulary. Okay, so what are the pathogenesis types of chronic gastritis? First, we have the superficial type. Chronic superficial gastritis that is usually involving the pyloric part. Pyloric part, this region. You get hyperemia. What is that? Increased blood volume in that region plus edema. And this is very important. This is how you differentiate between the two. Glands of lamina propria are intact. So the first type is superficial type. The second type is atrophic type. What is atrophy? Cell size decrease and organ size decrease. Okay. And the three types of causes of atrophic gastritis are these. Actually, it's labeled as type A, type B, type C, so you need to know that. It also is most common in the pyloric part, and it's seen in older people, and this is important, it's progressive. Chronic diseases are usually progressive. So hypertension, renal diseases, these are all progressive diseases. And you get intestinal metaplasia. So even in esophageal cancer, in adenocarcinoma, I said you get intestinal type features. So here we get intestinal metaplasia. So basically the cells look more like the intestine. Parietal cells will be decreased, chief cells decrease, and you get these absorptive columnar cells. Cells which are involved in absorption. That's the main function of the small intestine. Paneth cells, goblet cells increase, and you get a striated border. This can lead to dysplasia, and this can lead to metastatic intestinal type carcinoma. I'm sorry, I've been doing classes today since 8 a.m. So my voice is not really that good. Next, Zollinger-Ellison syndrome. So what's that? There is an atopic production of gastrin in the pancreas. So what is atopic production? This was done by Prashant. It's not supposed to be there. It's similar to atopic pregnancy. So usually the zygote must go and embed in the uterus, but it can go and embed somewhere else like the fallopian tube. That's called atopic pregnancy. Similarly, gastrin is supposed to be produced by the duodenum, but now it is being produced by the pancreas. So two locations are producing gastrin. So in Zollinger-Ellison syndrome, you get an excess in gastrin production. That leads to an increase in gastric acid production. Okay. Next, we have gastric carcinoma. So gastric carcinoma, the risk factors are usually chronic gastritis with H. pylori infection. Okay. So we have the intestinal type carcinoma. This is well differentiated. Remember what that means. It tends to divide slower. And you have the diffused carcinoma, which is poorly differentiated. Okay. Here are the risk factors for intestinal type carcinoma. Smoked food, pickled vegetables, salt intake high. And what do you mean by smoked food? People who love barbecues, then pickled vegetables. So in this case, we get an ulcer with a raised margin. What does that mean? This is the normal ulcer. I have taught you this before. But in this condition, we have a raised margin. You will hear this a lot in intestinal cancers also. So the margin here is raised. Okay. We have diffused carcinoma from native gastric mucus cells. And the reason, idiopathic. That means you don't know. People don't know why that is caused. The most commonly part involved is the pyloric part. Next is the cardiac part. Okay. So we have the early gastric carcinoma, similar to esophageal carcinoma. It's going to be the mucosa and the submucosa. Remember, the way it's the same concept for these types of cancers. Okay, the early gastric carcinomas will be of the mucosa and the submucosa. No involvement of the muscular layer till it advances to it becomes advanced diseases. If you detect it early, the survival rate is very good, over 90%. Next, we have advanced gastric carcinoma. This means the carcinoma has entered the muscular wall, spreads more widely, and shows 3 types of growth. You don't really need these, but basically exophytic, flat or depressed, or it could this is, let me show depressed. Or excavated, sorry. Okay. If the whole stomach wall is cancerous, if the entire wall of the stomach is replaced by cancer cells, it is called linitis plastica. Okay. This word is important. Linitis plastica, and it has an appearance like a leather bag. Okay. It looks and feels like a leather bag. Next, the final part of gastric diseases, stomach diseases, is peptic ulcers. Okay. Now, this is important. Chronic lesion on any area of the gastric GI tract. So it can be in the esophagus, it can be in the stomach, it can be in the duodenum, small intestine, large intestine, anywhere. But what is important for us in peptic ulcers is the action of peptic juices is going to cause the ulcer. And remember, peptic ulcer canceration is rare. Okay, peptic ulcer canceration risk is rare. So we have three types of ulcers. First, duodenal ulcers. Next, gastric ulcers, and finally multiple peptic ulcers. Now this is something you need to understand. Why are duodenal ulcers more common? It's 70% more common compared to gastric ulcers. Why is that? Our stomach is adapted to handle the acid. Okay, our stomach is adapted to handle the acid, but our intestine is not. So each time the acid comes and burns the duodenum, it will erode the layer, it will destroy the layer. So this is more common, and obviously you will get it in the first part of the duodenum. See, Zollinger-Ellison syndrome is a reason. It increases the risk due to obvious reasons, because HCl is going to be produced more now. It will come and burn the wall. It affects the anterior and the posterior walls. So the anterior walls and the posterior walls. And this is important. This decreases with meals, and usually the patient will have weight gain. Okay, in a patient who has duodenal ulcers, the pain will decrease with meals, the abdominal pain will decrease with meals, and this patient will usually exhibit weight gain. Okay, gastric ulcers, remember, there may be bicarbonates coming back into the gastric region. There can be a backflow, and that will bring along bicarbonate ions to neutralize the region. It can break down the mucus layer, exposing the wall to the acids. So as usual, the pyloric part is more common, and the lesser curvature of the stomach. I couldn't talk about this, but this is called the lesser curvature. And this is the greater curvature. So the lesser curvature is more commonly affected, this region basically. Okay. The pain will increase with meals because there's more acids produced, and you get weight loss because the patient doesn't want to eat. Okay, actually that's the reason. So in a duodenal ulcer, pain decreases with meals, so the patient tries to keep eating, and what happens then? You grow fat. In gastric ulcers, it's the opposite. The pain increases with meals, so you stop eating, so you have weight loss. So try to understand what's happening there. What is the reason for the ulcers to form? It is because the aggressive forces are stronger than the mucosal defense. So what are the defenses we have? We have mucus, we have bicarbonate ions released into mucus, and H plus is released as jets. So H plus is not just released outwards like this, it's sent upwards as jets, so that it won't touch the mucus layer, and then there's the mucosa to protect the layer against anything that falls down. Okay, this is not what happens, it's this one which happens. Okay, rapid epithelial regeneration, high mucosal blood flow, and high prostaglandins. This is inhibited in NSAIDs. Okay. Now, what is the hallmark of an ulcer? I have told you before. It's like it has been punched out. It's a region that has been punched out. So if you want to look at it, it will look like this. Okay, look at the angle here. It's 90 degrees. It's around 90 degrees. The diameter is around 2 to 4 centimeters, and the region adjacent to the ulcer will have mild edema. Okay, so the clinical features: recurrent boring pain in stomach, and the pain with a gastric ulcer is usually 1 to 2 hours after meal. That's when the food is in the stomach. Duodenal ulcers during the night, and 3 to 4 hours after meals. Okay. Complications. That is because the acidic food is now being released. Sorry, I will not go into explaining that. What are the complications? Hemorrhage. Underlying blood vessels can bleed, and that can lead to, again, hematemesis, melena, and fatal bleeding. Okay, you learned this for medical Chinese. You learned a condition in which there was gastric perforation. So basically we have the stomach, and this ulcer can perforate the stomach and bleed, and not bleed. Gastric contents can go into the peritoneal cavity. It can destroy everything. It can burn everything. Okay. Then we have pyloric stenosis. The pyloric region becomes thin, narrowed. Why? Due to constant inflammation. And people with pyloric stenosis usually have frequent vomiting, because the food can't go this way. It needs a way to go. It goes out. Okay. Perforation. This is what I said here, of the omentum, liver, pancreas. It's going to burn everything, like I said. Then it increases the risk of canceration. It increases the risk of canceration, but the risk is rare. Okay. Next, I want to talk about a small condition. It's called a diverticulum. Okay. So what's a diverticulum? It's a blind pouch. So we take the wall, and it's a blind pouch that protrudes from the alimentary tract but communicates with the lumen of the gut. So if you look from inside, you will see a communication. Here's the pouch, and there's a communication with the lumen. This is the lumen. You have a communication. I just want to tell you this word. Think of this as a word to remember. There's two types of diverticulum. One is called true diverticulum, in which all gut wall layers out pouch. Okay. So what does that mean? So let me draw a cross section of the wall. So all the layers of the wall are going to be involved in forming this pouch. Okay. All the wall layers are going to be involved in this condition. Okay. Next, we have false diverticulum. This is a diverticulum in which only the mucosa and the submucosa are involved. Okay. Look at the difference. Okay. An example for true diverticulum is Merkel's diverticulum, which is seen in infants. Again, I won't go into detail for that. Next, we'll talk about diseases of the intestine, the small intestine and the large intestine. So first, yeah, there's only a little more. First, there's two types of diseases. It both comes under a condition called inflammatory bowel diseases. Now I'm going to go a bit slow now. Inflammatory bowel diseases. It's a chronic inflammatory disease of the bowels. So first, we have ulcerative colitis. So what is ulcerative colitis? It is a condition in which there's going to be ulcerative inflammation of the rectal and the sigmoid column. This is where it's most common. And what you need to know is it spreads. It's progressive. Okay? And if it spreads up the colon, the descending colon, into the transverse colon, it's called extensive colitis. Okay? So we take a cross section of part of the colon which is affected by this condition, and then we look at it. You will see some pseudo polyps. Pseudo means false polyps, which are attempts to regenerate the normal mucosa. So the active disease, you get ulcers and inflammation. Okay? It can later become inactive, but with atrophy of cells. Okay? Oh, this is important. This involves only the upper layer, this mucosa plus submucosa. Okay? It's a superficial disease. Usually, in most cases, it begins in the rectum and progresses upwards. I showed this here. Okay? Relapsing and remitting disorder. Active disease can become inactive, can come again in cycles. Okay? The other disease is Crohn's disease. And before I go into that, these are some common symptoms for both types of IBDs. Okay, diarrhea, rectal bleeding, abdominal pain, tenesmus, weight loss, etc. So Crohn's disease, you get skip lesions. What do you mean by skip lesions? So here you can see the small intestine which I drew here, but basically the whole wall is not going to be affected. It's going to be skipped. Okay? Skip lesions. So this is the large intestine. This region is where it's most common, the ileal colonic region. But for NMU purposes, yeah. So you will see here, it's the junction where it's most common. It's a systemic inflammatory disease with predominant GI involvement. May affect any part of esophagus to anus, mostly small intestine and colon. So it's most commonly in this region. There's chronic mucosal inflammation and fibrosis. You get fissures. That's, you know what a fissure is. It's basically, you have the wall and you get, so if the wall was like this, you will see ingrowths. It has buried down, and you get non-caseating granulomas. Okay? And it increases the risk of carcinoma highest in the colon. So you get colon cancer, the risk is highest for colon cancer, same in ulcerative colitis. Okay, again skip lesions, and this is this is different from ulcerative colitis. This is a transmural disease. It affects the entire wall. Okay, so we have long, these are some features: long linear ulcers, what I drew here, fissures which are very deep, and fistulas can be formed. Remember what I talked about fistulas? Basically abnormal connections between two parts of the body. So this can communicate with another part of the intestine, another loop of the intestine. Okay, so I will talk about the differences. Ulcerative colitis is common in both genders, but Crohn's disease is more common in females. Okay, Crohn's disease is more common relative to ulcerative colitis, and you won't hear this much, but smoking is a protective factor for ulcerative colitis. Okay, so these people are actually told to go and smoke, unlike for Crohn's disease, which can aggravate it. Okay, the pathology, like I said, there's no skip lesions. It's a continuous inflammation that progresses. But for Crohn's disease, it's discontinuous, patchy with skip lesions. Okay, and the histology, this is a superficial inflammation, while this is a transmural inflammation. So what are the complications? Stenosis, abscess, colon cancer, fistula, and so on. This severe bleeding, rupture of the bowels, colon cancer, and a condition called toxic megacolon. Okay, you don't need to, this table is actually taken out of NMU, so you don't have to remember this. It's just for you to understand the condition. Okay, next, tumors of the large intestine. So there's 4 types. First, familial polyposis syndrome. This is a genetic disease. The risk factor is genetic, and you will learn it for genetics, so I will not go into detail there. Next, we have non-cancerous polyps. Okay, these polyps are non-cancerous. You can't differentiate it just by looking at it. You need to do a biopsy. I have told you this before. So it's non-malignant, hyperplastic polyps, hyperplasia, nipple-like and smooth. You can see. Okay, and often it's multiple. So just remember this diagram. You can add this, and just remember this diagram. Okay, and it's more common in the rectosigmoid region. Okay, the final parts of this region, same region. Okay, next we have adenomas. Okay, so basically what is adenoma? It is a cancer originating from the epithelial cells. Okay, so epithelial proliferation can lead to dysplasia. It can lead to adenomatous polyp formation, which is a precursor to carcinoma, and it is located in the colon and the rectum. So whenever you find one on biopsy or during some scan, you need to always do an excision. Otherwise, it can become a cancer. Okay. First, we have tubular adenomas. This is the most common type, and it involves the rectal sigmoid region. I showed you where. Single or multiple. Actually, this is the image. And it has a head. Slim stalk, 1 to 2 centimeters long, and has a head. Okay, has a stalk. This region is the head. It looks like a penis. Okay, often well differentiated. So if you want, I'll just draw it on this. Okay, it's a protruding mass outwards. Next, we have the villous adenomas. Okay, this is this will lead to formation of an invasive carcinoma. It's very rare. It's only 1% seen in older people. It's larger than tubular adenomas and has a velvety mass. Okay, this is that. Sorry, this is villous adenoma. And this is tubular villous adenoma. This is more common than villous adenoma. It's a mix of both types. Okay. Malignant risk of adenomas depends on the polyp size. This is important. Okay. The risk of the adenoma becoming malignant depends mainly on the polyp type, the histology, and severe epithelial dysplasia. The main thing is the polyp type. But the problem is the smaller ones are usually asymptomatic, and then you will have occult bleeding. What is occult bleeding? That is basically bleeding which you cannot see to the eye. Okay, you get it especially with villous adenoma. Okay, and that can actually lead to significant anemia because you don't know that you're bleeding. You don't know that you're bleeding. It's occult bleeding. It can lead to significant anemia. Okay, next we have colorectal carcinomas. I told you for a male, prostate cancer is the most common type of cancer. Next, lung cancer. Colorectal carcinomas are the third most common type of cancer and the third most leading cancer deaths. Okay, what are the risk factors? People who eat less fibers. Okay, people who do not like green vegetables, basically, and that is the main risk factor. Others include people who love refined sugar, sweets and stuff, sweets which have very high glycemic indexes, high fat content. So people who eat a lot of fatty food, plus people with cystic fibrosis like diseases, they have a high risk. And a decrease in the protective vitamins. You will learn these three vitamins a lot. Vitamin A, C, E. Okay, I remember it as ACE. And 90% of cancers of the large intestines are adenocarcinoma in origin, which originated from an adenomatous polyp. Okay, but the opposite of this, squamous cell, you get the anal region undergoes squamous cell carcinomas. Okay, you don't get adenocarcinoma in the anus, you get squamous cell carcinoma in the anus. Okay, I will explain how this process happens, but first I want to just go through what you will learn. So we have different types of growths. One is the polypoid type, ulcerative type, and infiltrative type. Polyp growth, ulcer, and you can see the margin. Okay, the mucosa around ulcer has heaped up. That's obvious. So this is the ulcer. You can see the mucosa heaped up. Irregular shaped, blood and necrotic tissue can be seen. So you get bleeding. Those who were there for my class, I talked to you about an example. A person I know who had the red toilet, so he did not even know he was bleeding. Okay. And there's 3 levels of this carcinoma formation. This high-grade intraepithelial neoplasia. This is basically carcinoma in situ. It hasn't penetrated into the bottom layers. It's still within the confinements of the basement membrane. And next, intramucous neoplasia. It has entered the mucosa layer, but still hasn't started spreading. And finally, we have the invasive colorectal carcinoma, which can spread to the prostate, bladder, or peritoneum. Okay, these are the structures close by to that. Then it can go into lymph spread, hematogenic spread, and this is important. These patients are usually asymptomatic for years, and suddenly within a few months they get all the symptoms, and usually it's too late to do anything. Okay. Now let me just explain the progress of these cancers. So first we have epithelial dysplasia. Okay. Next we have adenomatous polyp. Okay, and that can lead to colorectal carcinoma. And there's 3 names: high-grade intraepithelial, within the epithelial neoplasia. Next, intramucous neoplasia. Finally, invasive colorectal. So basically carcinoma in situ, mucosa invaded, and finally invasion through the whole wall. Or it can spread to other locations such as the prostate, bladder, peritoneum. Okay, so you need to know these cancers. The final part of GI pathology is appendicitis. Okay. This is the most common acute abdominal condition for surgery. Okay, what does that mean? Basically, if you go to a OR or you go to a surgery clinic, in one day you will have at least 2 to 3 patients with appendicitis. Okay, it's that common. The most common cause is because of the appendix. You know that the appendix is called a vestigial organ because it's useless. For humans, it's useless. For cows, yes, there's a function. It breaks down fibers. Okay. First, there can be an obstruction that will lead to ischemia and bacteria. Remember, the large intestine is full of bacteria. It could be anaerobic bacteria. Now that's more dangerous. Anaerobic bacteria are more dangerous than aerobic bacteria. They will grow. Okay, and then our body tries to attack it. Inflammation, appendicitis, ITIS, it's inflammation. So our body tries to attack it. What happens then? You get different symptoms. Initially you get a lower abdominal pain on the right side. So then if the patient is suspected to be of appendicitis, you can start off with antibiotics. If it is a mild state, that's good enough. patient's abdominal pain will disappear, patient will be fine. Okay, but if the treatment is not given on time, it can progress into different stages. The first stage is called acute suppurative appendicitis. Okay, the dangerous condition is if it becomes gangrenous. Okay, because that can burst and all the bacteria and the purulent substances can go and infect the peritoneum, and it can actually lead to death. Okay, so let me just go through this slowly. You use antibiotics, you can get rid of that. You will see on histology, you will see the appendix has enlarged slightly. This is early acute appendicitis. Okay, next, the acute suppurative appendicitis. You get abscess formation, ulcers, necrosis, all here. Okay, and the structure looks reddish yellow. Okay, and finally it can become gangrenous. Then it's red black, because everything is going to be destroyed. You have seen a gangrenous intestine, you know what it looks like. And if it perforates, if it can perforate to all these purulent substances can enter into the peritoneum, and that's dangerous, very dangerous. But basically, by the time it comes to this part, the patient is in a lot of pain. Like, the patient is in unimaginable pain that he will actually fall down on the road or wherever he is, holding the stomach. It's as if he thinks he's going to die. Okay, so that's it for appendicitis and for GI diseases. I hope you understood what was taught. I had to go a bit fast because I had to keep it under 1.5 hours. I kept it for 1 hour 12 minutes. So I'll see you guys in the next lecture.